Good evening and welcome everybody. Noswaith dda a chroeso pawb. My name is Colin Reardon. I'm the President and Vice Chancellor of Cardiff University. It's a huge pleasure to be able to present and host this digital showcase this evening, which, as you know, is entitled Menstruation to Menopause, a Reproductive Mental Health Journey. Thanks so much for joining us this evening. You're all part of the Cardiff community, which comprises alumni, staff, donors and friends who are supporting the learning and research of the university, and you're all very welcome. As you'll have seen at the beginning, those of you who joined just at the start there, the digital showcase tonight is going to be recorded or is being recorded, and we'll send you the recording link after the event, and you're obviously welcome to share that because we want to get the word out about our amazing work and research here. So tonight's event showcases one of our mental health and neuroscience programs, and we have two speakers from the National Centre for Mental Health, hosted by Cardiff University, and it brings together researchers from Cardiff, Bangor and Swansea universities and from the NHS, and it's funded by the Welsh Government. I think we're all aware of the burden that mental health problems place on society. There's 1 in 4 people are affected by issues like this every year. And the National Centre for Mental Health researchers are looking into and researching and investigating what causes mental health conditions and illness, whether that's from the environment or from life experience, but also through genetics and our biological makeup. And clearly, if we can understand the causes better and the interplay between these different factors, we can work to develop better diagnosis, better treatment and support for the future. So this evening we're focusing on mental health in women, and we're going to be hearing from 2 leading experts in this area, Professor Ian Jones, Professor of Psychiatry, who's the Centre's Director, and with him's Dr Arianna Di Florio, as Clinical Senior Lecturer and Psychiatrist, both the Cardiff University alumni, like some of you. We'll be hearing from Ian and Arianna shortly, and following that we'll have the opportunity for questions and answers, which you'll be able to type in the usual webinar fashion. We have some questions in advance, so I'll be starting with those in case you need to collect your thoughts, but if you want to put any questions during the talks and or afterwards, put them in the Q&A box in the bottom of your screen, or maybe situated somewhere else depending on your device, but there'll be a Q&A box and we'll try to answer as many as time allows, and if we can't get through them, we'll follow up with you subsequently. But for the moment, I'm delighted to welcome Professor Ian Jones, who's going to start the presentation, and he will introduce Arianna afterwards. So over to you, Ian. Thank you.
Excellent. Thank you very much, Vice Chancellor, for those kind words of introduction. Let me just share my screen. Okay, I'm hoping that's all working. Okay, so what we're going to do for the next 25 minutes or so is take you on this reproductive mental health journey, hoping that we'll say something about the journey that we've taken as a research group in the university. And thinking of that, our journey started with our work in bipolar disorder. So we're all up to speed. Bipolar disorder is a severe mood disorder, affects something like 1 to 3% of the population, and people with lived experience of bipolar disorder have significant depressive episodes of low mood, but also are vulnerable to episodes of high mood, of mania or hypomania. And when I joined Cardiff University and worked in my first research job, I had a job where I was going all over the UK to interview participants for our research with bipolar disorder. And what struck me in those interviews was the women I was talking to would very often say that their first episode, or a very significant episode, was a severe episode triggered by childbirth. Now, this link between childbirth and severe mental illness isn't new. This has been known about, written about for hundreds, if not thousands of years. Some people recognize writings in the ancient Greece that talked about postpartum episodes. But certainly when medical textbooks began to be written in Europe in the 17th and 18th century, 16th and 17th centuries, there were accounts of women with severe recurrent postpartum episodes. But these conditions aren't of historical interest only, and that's no better illustrated by the findings of the confidential inquiries into maternal deaths, which, when suicide was included in those inquiries, people were shocked to realize that actually suicide was the leading cause of maternal death in the Western, in developed countries. So what do we know about this condition, postpartum, what used to be called puerperal psychosis, but we kind of gone American and kind of used the term postpartum now. Nobody could really say puerperal, certainly nobody could spell it, and I'm not the only clinician to have received referrals from women with a history of puerperal psychosis. What are we talking about? We're talking about a severe illness that impacts around 1 in 1,000 women. In around 50% of cases, this might be the woman's first severe episode of psychiatric illness. Its onset is very typically in the first few weeks, usually the first week or two postpartum, and this is an illness that has a very good prognosis. Women tend to recover within weeks or months. And as far as the symptoms are concerned, we're talking about a severe mood episode with low mood and high mood, and more often than we see at other times, kind of what we call a mixed picture with high mood and low mood symptoms all occurring together. And psychosis, delusions, believing things that aren't true, hallucinations, seeing, hearing things that aren't there. And the other classic description of postpartum psychosis, which is really accurate, I think, is it's said to show a kaleidoscopic presentation, like looking through a kaleidoscope when you're a child, when the pattern is constantly changing. That's the clinical presentation we tend to see with these episodes, that women don't slowly develop psychotic symptoms that are very fixed for many months, but can change very rapidly, even from hour to hour. Postpartum psychosis is a psychiatric emergency, requires medication in the early phases of treatment and admission to hospital, but that's not to say that psychological treatments helping women come to terms with what's happened to them are really important in the longer term. So why is it important to do the research that we're doing into postpartum psychosis and understanding more about what causes this condition and who is at high risk? Well, it will really help us. I'm a clinician, psychiatrist. I sit with women and their partners, trying to help them make such difficult decisions about pregnancy and particularly about whether to continue or stop medication. And I think if we can understand better who is at risk of this condition, and how to predict that, that will really help women make those decisions. I think there's a unrivaled opportunity to work with women in a preventative way. That, women in this scenario, we see women who are currently well, who have maybe a 50%, 60% or more chance of becoming ill in a defined 2-week period, and become as ill as we see people in psychiatric services. Nowhere else do we have that opportunity to work in such a preventative way. And lastly, why this is important, and this is the motivation that motivates the work that we're doing in our research group. We think this link, this triggering of illness by childbirth, is something that can really help us understand the etiology, the pathophysiology, the biology of this triggering. And that will help us not just understand about postpartum psychosis, but to help us understand more about the causes of mood disorders and psychotic illness more generally. So let me tell you something about the work that we've done. It's been a collaboration between our group in Cardiff and Professor Lisa Jones's group, which was at Birmingham, but has recently moved in recent years to the University of Worcester. And we've been incredibly successful thanks to both clinical services that we worked with, to third sector organisations like APP and Bipolar UK, who've worked with us brilliantly to recruit. But most of all, the thanks needs to go to the women themselves who've participated. We've recruited over 7,000 individuals with bipolar disorder across the UK. It's the biggest study of bipolar disorder in the world. And actually, because of our interest in perinatal episodes. We've questioned all the women really closely, pregnancy by pregnancy, to get information and data about episodes in relation to childbirth. What's the output of this work? Well, it's been enormously successful. The BDRN study has generated well over 100 papers, and I'm just going to take the opportunity just to highlight a couple today that have particular relevance for this area. What have we shown? Well, we've shown that women with bipolar disorder are at very high risk of an episode in pregnancy or the postpartum period. And women with the most severe forms of bipolar disorder, the so-called bipolar 1 disorder, are at very high risk of an episode of postpartum psychosis. You see the right-hand side of the graph there, the dark, the back bar shows that women with bipolar 1 disorder are at something like a 1 in 5, a 20% chance of suffering a postpartum psychosis episode after each delivery. Compare that with that risk in the general population of 1 in 1,000. The other things that we've been able to do is individualize that risk even further. This is probably one of the most clinically useful bits of work that's come out of the group to date. And that's on the basis of a couple of simple questions. We can identify women with bipolar disorder that are at a 45% risk of postpartum psychosis, and women still with bipolar disorder, still in that high-risk group, that are at about a 1% risk of postpartum psychosis. And I think those kind of differences can really help us in our consultations with women to make those difficult decisions and make decisions about continuing or stopping medication. And finally, there's a range of studies that we've done on the genetics, on the immunological factors, on hormonal factors, looking at the causes. I've just picked out one study by a fantastic postdoc that's working with us, who's just started on a welcome 5-year fellowship program, Katie Lewis, and she showed that women who were vulnerable to sleep disruption in triggering their manic episode, their high episodes, were twice as likely to suffer an episode of postpartum psychosis, suggesting perhaps that circadian rhythm disruption was an important etiological factor that we need to take into account. And then finally, we've done a lot of work. There's a lot of work being done. I hope I've given you a little bit of a flavor of that already, but there's lots more work to do. We need to understand better what are the causes of this condition, and for that, we need bigger cohorts of women with PP, and we're about to launch a big national online drive recruiting women with postpartum psychosis, the MAN-PP study. And also we've got funding and got agreement for the 23 mother and baby units around the country to begin recruitment to a mother and baby unit cohort. So we'll be able to offer research participation to all women with PP that come through the mother and baby units. But, and this is key, I think, we need to work better to understand how to deliver the insights that our researchers already given to women with bipolar disorder and who are at high risk of postpartum psychosis. And to do this, we're working with a fantastic student, Ellen, who's about to do her PhD viva next week on this work. It's a collaboration, it's co-production with third sector organisations, Action on Postpartum Psychosis and Bipolar UK, and we've produced with women a interactive guide that women can use and to lead that discussion with their clinicians in planning pregnancy and optimising their care. But it's not just academic outputs that's important, and our work with the third sector organisations here is key. Having impact, making a difference to women and their families is how ultimately our research will be judged. And we've done a number of things that have really helped in that regard. I think we've worked with the Maternal Mental Health Alliance, which I'm a trustee of, on their campaign Everybody's Business. On the basis of our research, we demonstrated the need for specialist perinatal mental health services, and the campaign has been amazingly successful, resulted in over 500 million of increased funding, new funding to establish perinatal mental health services across the UK, and the graph just shows there, the colour coding shows, red, amber and green, that services are developing throughout Wales, and the same is happening throughout England. And the other thing, probably the most important thing I've done in my working life actually, is work to reduce the stigma of postpartum psychosis. And for that, along with colleagues from Bipolar UK and APP, we went and pitched to the producers of EastEnders that they should cover this story, and they did it incredibly well, reached over 12 million people with their Christmas story, in which Stacey developed postpartum psychosis, and we acted as a script consultant for that with them. So finally then, before I hand over to Arianna, I just wanted to say why Cardiff is such a great place to do this work. We have unrivaled access to cohorts of individuals with mental health conditions through NCMH, through BDRN. We have world leading, and we probably are the world leading psychiatric genetics group. We have superb neuroscience, and I'm absolutely delighted that we've also got a fantastic medicine discovery institute now, and I've been in discussion with John Antack and other members of the MDI, and we've massively pleased to have landed a couple of large grants from the MRC and Wellcome to look for drug treatments, new drug treatments for perinatal condition. And then, complete in the loop, we have those contacts with the NHS and with the third sector to ensure that the fruits of our research get fed back in and disseminated to those women and to those clinicians who need to hear it. So that's why I think Cardiff is a brilliant place to do this work. I've told you a little bit about our work in postpartum psychosis. I'm going to hand over now to Arianna, who's going to carry on and talk about our work and the development and the advances of our work looking in menstrual disorders and the menopause. So with that, let me hand over to Arianna.
Thank you, Ian. Thank you, Vice Chancellor, for inviting me. It's great to be here this evening. So, building on Ian's presentation, I'm going to expand the discussion and argue for diversity. Diversity in reproductive life, but also racial and cultural diversity. Stereotypes have been affecting Western medicine for the past 50 years at least. 40 years apart, these two advertisements convey the same message. There is something wrong with mothers who don't conform with the efficient, happy Caucasian beauty stereotype. These issues are framed as medical needs to be fixed by purchasing pills or surgery. These images also exemplify the broader issue of considering women only in relation to motherhood. Little space is given to other aspects of their biological and psychological lives. Take, for example, perimenopause, the period surrounding the final menstruation. On the vertical axis here, a rough approximation of the proportion of people who will have the disorder. On the horizontal axis, the number of clinical trials available for each topic in a search I ran last week using the Electronic National Library of Medicine database. For postpartum depression, a disorder affecting motherhood, there were 25 times more publications than for perimenopause depression, a disorder affecting older women. When a male-specific disorder, such as erectile dysfunction, is considered, the difference is abysmal. There are over 100 times more publications on erectile dysfunction than there are on perimenopause depression. This trend is reflected in a recent survey we conducted on 81 UK medical students on premenstrual dysphoric disorder, a cyclical mood disorder affecting about 5% of individuals with menstrual cycles in the weeks before the menstruation. Only 4 students had basic adequate knowledge of the disorder. Jessica Cotter, the student who ran the survey, had to really insist to get responses from male students, highlighted again an important gender gap. To break the vicious circle between the lack of information and negative stereotypes, we have set up a reproductive mental health program in Cardiff, which integrates research with teaching and clinical practice. This is the first program of this kind in the United Kingdom. Our research is currently funded by the Wellcome Trust, the Global Challenge Research Fund, the Medical Research Council, the European Research Council, and the Brain and Behaviour Research Foundation. Our clinic is a UK-wide free of charge service providing second opinions on complex psychiatric disorders associated with reproduction and on gender-sensitive diagnosis and management of severe mental illness. We also hope to have soon the resources to develop, with the help of women with lived experience, educational resources for prospective healthcare professionals, in particular medical students, and to include reproductive psychiatry as an important part of the medical undergraduate curriculum. My brief talk, however, will focus on the research side, which again has been made possible thanks to the support of several international and national funding bodies. Research in this area cannot assume that we live in a culture-free world, but needs to acknowledge the presence of multiple cultural forces. In our program, we aim to integrate too often opposite views. On one side, the biomedical paradigm, which focuses on disease states and tends to overlook environmental and societal factors. And on the other side, social and ecological views, especially the feminist critique, which emphasizes the detrimental role of patriarchy and tends to reduce most women's psychiatric disorders to expressions of male oppression. These polarized views, in my opinion, forget that all women are different. And at the heart of our program's vision lies the assumption that all women are indeed different, and the approach to their health should follow their different and specific needs. One thing for sure that is different in all of us is our genetic makeup. Reiterating what Ian said, Cardiff University is a world leader in psychiatric genetics. Building on the exceptional world-leading resources and expertise of the MRC Centre for Neuropsychiatric Genetics and Genomics and the National Centre for Mental Health, we're now conducting the largest study ever conducted in reproductive psychiatry by including 3,000 women with psychiatric disorders triggered by reproductive events to understand why women respond differently to normal changes in sex steroids and what are the genetic factors contributing to these differences. Why did we choose genetics? Well, DNA is fixed at birth and it's the same in all cells. So the information we get does not change with time, and it's the same whatever tissues we choose to study. This makes DNA collection as easy as spitting, much less painful, for example, than the COVID test we are all doing at this time. So how does DNA work? If you go to the Wellcome collection in London, they used to display these books here. If you look at their content, you'll discover that they are written just using 4 letters. These letters are the building blocks of our genetic code, the DNA. This one wall of books represent the code for just one person. Now, the code is almost identical for all of us, which makes us unique from a genetic perspective. It's less than 1% of the code that we can call here spelling variations or mistakes. We also know that a significant part of our risk of developing common disorders, including psychiatric disorders, is due to many spelling variations of mistakes that taken singularly don't have any big effect. But if it is their accumulation that increases our risk of disease. This is a very important point, exploited in many areas of modern Western medicine, way beyond what we are discussing today. As you might well encounter these concepts again in the future, I'll try to explain them to you using the code book metaphor. So let's say we're interested in the likelihood that a person is a native British English speaker, okay? If you have a group of individuals and each person has written a book, the distribution of the number of spelling mistakes in the book will follow a bell shape, this bell shape here. Most individuals will make an average number of mistakes here in the middle, while only very few will have no spelling mistakes at all, or on the opposite side, a lot of spelling mistakes, making the book almost impossible to read. The more spelling mistake you make, the less likely you are to be a native speaker. So, for example, Ian will make some spelling mistakes, however, not many. By reading his book, you'll conclude that Ian is quite likely a native speaker. Now, if the same book is written by me, in this case, there will be many mistakes, many more than the average population, and you'll conclude I'm probably not a native speaker. So going back to the DNA, the graph is quite similar. Here in gray is the risk, for example, of having bipolar disorder, which increases with the number of spelling mistakes that here we will call polygeny risk scores. Now I'm going to show you an application of this example of how genetics can help address long-standing clinical controversies. So Ian told you about postpartum psychosis and bipolar disorder. Postpartum psychosis is currently not recognized by the official diagnostic systems at the detriment of women. Women who suffer postpartum psychosis usually receive a label of bipolar disorder regarding the lifetime history. So for example, let's take 3 women here. They all have a label of bipolar disorder according to the official diagnostic systems. However, if we follow them up from their own birth to 6 weeks after they give birth, we find that they have different life trajectories. So the first woman, despite having bipolar disorder, this woman here, does not become ill after giving birth. The second woman instead becomes ill also after giving birth. The third woman had never been ill before, never had any mental illness until immediately after giving birth, when she develops postpartum psychosis. So we ask ourselves, can genetics help distinguish these 3 groups of women? So what we did is to calculate out the bell shapes I just explained to you for the various polygeny risk scores for the 3 groups of women and for female controls from the general population. Here the controls are in red. We didn't find any difference between women with pre-existing bipolar disorder with or without postpartum psychosis. So the first 2 groups here in light gray and the blue bell shapes. We, however, did find differences with the 3rd group here below. So women with first onset postpartum psychosis in the bell shapes are in green. So therefore, we concluded that bipolar disorder and first onset postpartum psychosis are not exactly the same. So the controversy on whether postpartum psychosis is bipolar disorder or not has been going on for over 150 years. Clinical wisdom and research had already suggested that it's useful to make a distinction between postpartum psychosis and bipolar disorder, but there was not enough for an official recognition. Our study here is the first evidence supporting the biological validity of this distinction between bipolar disorder and postpartum psychosis. It is a necessary milestone towards the official acknowledgement of postpartum psychosis by diagnostic systems, with important implications for research and for clinical practice. Our plan now is to run similar analysis for disorders triggered by the menstrual cycle and by the perimenopause. An important aspect of genetic research is diversity and the inclusion of people of non-European genetic backgrounds. We've argued that genetic research should also consider the impact of culture. For example, this is a large international study of postpartum depression that we led a few years ago. Without going outside Western cultures, so we found that the way women report postpartum depression differs significantly between the EU and the United States and across educational levels, more than with the color of the skin. The impact of culture is, of course, even more striking when comparisons include non-Western cultures. We have therefore set up and are leading an international consortium involving women with lived experience and stakeholders from different geographical, linguistic, and socioeconomic backgrounds worldwide to develop culturally sensitive research approaches. These innovative systems of doing research will allow clinical and biological research to be impactful beyond the Western world, hopefully providing appropriate care for all women who need it. I conclude by thanking Team Cardiff and beyond. Diolch am I silo.
Well, thanks very much indeed, Arianna and Ian. That really was. I just have to agree with with Debbie Wharton, who's put a comment in the chat there and a question, that it is so interesting. Awful lot there. I think a lot of people wouldn't be aware of. And Debbie's got quite a specific question about a condition that her daughter's suffering, and I wonder whether we can point you in the right direction, Debbie, more directly. But there are some sort of general questions. Is there help available on the NHS, and are there support groups for girls suffering with this? So this is about the effects of menstruation. Don't know who's best placed to have a word about that.
Shall I kick off and say something about this really important but very difficult issue about getting help? It's undoubtedly an area that the NHS needs to do better, and I think whoever are the clinicians involved in your care, raising those issues, those links that Debbie has noted about the links between her daughter's condition and her menstrual cycle. I think those are really important issues to raise. I think we're probably at a stage back in the way that and Arianna rightly pointed out that this is an area that lacks funding for research, but also for clinical services as well. Where there has been massive changes, and I think that it is in dealing with perinatal mental health conditions around in pregnancy and childbirth. And I think the recognition of the importance came first, and then the campaign for better services, and that's really paid dividends. So my only hope is that this is something that clinicians become more aware of. I think our research and the fact that Arianna's been successful in getting this big European funding to do this research is a good sign, but that may take some time to work its way through into clinical practice. So Arianna, I don't know if you have anything to say about kind of support groups and things for in this area.
So one thing that I really like about research in this area is that women with lived experience are absolutely amazing and very active, and they are really, because of the lack of support in general and awareness, they're really doing an amazing work themselves. And there is a specific, for the specific question that Debbie, and I'm very sorry for her daughter, is posing here. We work with the International Association for Premenstrual Disorders, and I would be more than happy to provide the details perhaps after this talk. They're doing really amazing work on this.
Great, thanks very much, Arianna. There's a question about whether if a woman has had postpartum psychosis with her first baby, is the risk greater or equal, or what with the subsequent births?
Who's best to take this one, Arianna? Do you want to take this first? You've published a really important publication that addressed this exact issue.
Yes, of course, the history of the personal history is a really important element to determine the risk of becoming unwell with the subsequent pregnancies. I think it's also other factors are important. It's not that it's an absolutely, it's the destiny. There are more factors that might modify the risk, which I think are important to consider. And it's also important to consider that the background in general moms also without depression is still quite a common illness. So that is certainly a factor that increases the risk, but that doesn't mean that is what is going to happen.
Thanks. I mean, it kind of leads on to a couple of questions that I'll sort of merge a bit, which is how much awareness is there of the link between menopause and depression? I guess one would put menstruation in there as well. I think everybody's pretty well aware of what we generally call postnatal depression. But how much is awareness of the link between menopause and also menstruation depression amongst clinical professionals? GPs, other professionals? What is the awareness like in your experience?
Can I answer, Ian?
Certainly, Arianna, you go first.
I think I've shown you the data, for example, for premenstrual dysphoria disorders in UK, in general in UK medical students. And I think it's, in my experience, talking with women, it's not different in grown-up doctors, let's say. And I've also shown you the evidence that's available to doctors on the perimenopause, so on reproductive aging. And again, that there is no much around. I think we're talking more about these things, but I'm not sure the evidence is there. So now we know we have a problem, but I'm not sure we are at the stage in which we can quantify it and try to sort it out. We will need more research. I'm sure we're going in the right direction, but still a lot needs to be done.
If I can jump in there and just say, I think the direction that we've taken in perinatal services is really encouraging here, because we including us have done research that have shown the need. That's led to campaigns for better services, which has actually led to the government putting across the UK, in Wales and England, Scotland and Northern Ireland now, kind of actually funding the services, funding training, and leading to what the situation we may have been in with regard to perinatal mental health 20 years ago, with perhaps in the currently, as far with regard to episodes in relation to the menstrual cycle and the menopause. But I have great hope that if we continue on the path we are, that things will get better. And I think getting that funding, doing that research is a really important first step in making that progress that can lead to that impact for women, that's so clearly needed.
I understand that funding for mental health research is much more difficult, or at least it's smaller in quantum than for other very common conditions. And I guess in this case, it's even more difficult. So we're looking at an area that is deeply underfunded. Is that right?
Undoubtedly, Vice Chancellor. It's definitely the case. I think, mental health, as you say, doesn't get its fair share. And within mental health, these conditions that predominantly affect women, and that, as Arianna has pointed out, reflects some kind of institutional sexism. I think in these are even more orphan disorders, as Arianna put it, and underfunded areas. So the fact that in Cardiff we're developing this work, the fact that we've been successful in getting funding, I think is a good first step, but clearly more work is needed.
So there's another question in the chat, slightly related to this. Are there any results or studies for women who have disabilities, in particular menopause changes for women with learning disabilities? There's a huge gap in support and awareness for this population.
If I can just kick off with that before Arianna comes, just to say, I think if there's an area that's even more understudied, it's that. But we have a very active learning disability, intellectual disability component to our centre, and it's certainly something that Cardiff may be very well set up to look at. But so that's given me some ideas there that I can take back to the National Centre, have some conversations with people, and and look to develop that work that's needed further. Arianna, I don't know if you've got any further things to add.
It's fantastic that this is mentioned, and it's a very important point, because the little funding is usually given to less severe conditions. And this is actually a concept that a Welsh GP developed 50 years ago now, and that we tend to support people that need the less. So people that need a lot of care actually are the ones that usually suffer and are the least supported by the system. So actually, this point is a very important one, and it's a brilliant idea, and it's fantastic that this has been mentioned. It energizes this research. Absolutely, it's an important effort.
Thank you. We've only got 4 minutes left now, because we do need to finish at 6. But a couple of quick questions, if we can. Others that we don't get round to, by the way, we will answer afterwards. via email. Would it be beneficial to screen girls who start their menstruation but also exhibit severe mental distress? I guess just these things happening at the same time as being at risk of bipolar as they get older. Is that a risk factor?
Arianna, have you got any thoughts on that?
I don't think we have a firm answer to say anything. And because the way we are there is little research, it's easy then to say one thing that then, more robust research will disprove. It's absolutely important to be aware, I think, of conditions, but we don't want to go on the side that then we overdiagnose women, because we have a history to label of women as crazy, right? And there is a lot of history on that side. So it's about finding the balance between denying a problem and overdiagnosing women and say, oh, women have problems. And I think more research, again, is needed on this.
Yeah, I agree with that, and I think one of the important questions that raises is if you have one form of reproductive mental health condition, does that raise your risk of others? And that's definitely something that our research program will be addressing. So hopefully, watch this space. We might have more information on that in years to come.
There's a question there about, is there a link between endometriosis and mental illness? Endometriosis is another, really difficult problem.
Ian, do you want me to say something?
I think it's another understudied, under-researched area, and clearly can be involved. It's an area which we try and obtain information about that will allow us to look at those associations. I'm just trying to rack my brains to think I'm aware of any work that's been done already, Arianna. I don't know if you are, but certainly it's an important aspect that needs to be taken into account in the research that we're doing.
There's probably an awful lot of questions on that type of style. What's the link between various other? So perhaps that's something we could follow up with. Just before I close, somebody's asked how women can learn more. Where to look to learn more about the impact of their menstrual cycle on the mental health. To develop the knowledge. Where could they look? Are there websites, or what's the best thing to do there?
I think that the patients' organizations usually have the best material, actually. But again, the issue is that what we have, everybody, is not much. But if there is, what is available is definitely available through patient support organizations.
And I think our National Centre for Mental Health website is a good source of information as well. And also, somebody else asked about participating in research. There's opportunities there to sign up and join our register of patients who volunteered to participate, and so I can point people in that direction as well.
That's great. Well, look, thank you both so much. That was really tremendous, and I must say, very, very enlightening. In such a short time to be able to develop our knowledge so much was a real achievement. Thank you, and thanks also, Diolch to our audience. For being with us. If you didn't get, as I've said, a chance to get an answer to your question, we will follow up, and you'll get an email in the next few days with a copy of the recording and links to register for upcoming events. So the next one's after Christmas on Thursday, the 13th of January, and there the showcase is going to be research into polycystic ovary syndrome and its long-term effect on mental and cardiometabolic health. So we hope you can join us for that one. And if anyone watching would like to get involved with Cardiff University, whether that's volunteering time, perhaps even taking part in research or helping us to fundraise for our research, and we've heard what the real need is there, please do follow the link in the comments box, which is there for you. So, diolch yn fawr iawn, a hwyl. Thanks very much, everybody, and goodbye. See you next time, I hope.